Hi everyone, welcome back to Learn with MedNuggets. In today's video, we will be talking about Graves' disease. So what is Graves' disease? Graves is an autoimmune disorder that causes hyperthyroidism, meaning the thyroid produces too much thyroid hormones. Here's how the disease develops step by step. Number 1. Immune system malfunction. In Graves' disease, the immune system becomes misguided and mistakenly targets the thyroid gland. Normally, our immune system helps protect the body from infections by attacking foreign invaders like bacteria and viruses. But in Graves' disease, our immune system targets the thyroid as if it's a foreign threat. Number 2. Production of autoantibodies, also known as TRAPS. So now, instead of attacking a pathogen, the immune system creates autoantibodies that specifically target the thyroid gland. These antibodies are called thyroid-stimulating hormone receptor antibodies, or TRAPs. So what's the big deal with TRAPs? Well, the big deal is these weird antibodies mimic the action of TSH, which is the hormone that normally stimulates the thyroid gland to produce thyroid hormones. So in Graves' disease, these TRAPs are going to act similarly. They are going to bind to TSH receptors on the thyroid gland just like TSH would. This constant stimulation makes the thyroid gland overproduce thyroid hormones. As a result, thyroid hormone levels in the blood rise, leading to hyperthyroidism. Number 3. Excess thyroid hormone effects. The excess thyroid hormones speed up the body's metabolism. This leads to classic symptoms of hyperthyroidism such as weight loss, increased heart rate, anxiety, irritability, heat intolerance, which means feeling hot in cool temperatures, tremors, and fatigue. Number 4. Effects beyond the thyroid gland. What makes Graves' disease so unique is the signs and symptoms it causes beyond the level of the thyroid gland. In other words, you're going to hear from patients or see a few other signs and symptoms other than the classic signs and symptoms of hyperthyroidism. So why does this happen? Well, TRAPs attach to TSH receptors, right? Now the thing is, there are a few other places in your body that contain these receptors other than your thyroid glands. These receptors can be found in your eyes, specifically in the orbital fibroblasts, which are the cells in the connective tissue behind the eyes and in the orbital muscle cells. These tissues are involved in the normal movement and positioning of your eyes. So when TSH receptor antibodies bind and overstimulate these receptors, it triggers an inflammatory response which results in the production and accumulation of glycosaminoglycans, particularly hyaluronic acid, in the orbital tissues. GAGs love water and are therefore going to draw water, which causes the tissues behind the eyes to swell and expand and push the eyeball forward, causing it to bulge. So on physical exam, you'll be able to see an eye that looks like this. Normally, our eyes would look like this. The sclera of the eye at the top and bottom are not visible. But in Graves' disease, when the eye is pushed forward, your sclera becomes visible. We call this exophthalmos. TSH receptors are also found in bones and skin, therefore TRAPs will bind to these receptors and may activate fibroblasts. These activated fibroblasts can cause the abnormal accumulation of extracellular matrix components like collagen in the skin and bone tissues of the fingers and toes. This can lead to swelling and deformities of the fingers and toes, a condition known as thyroid acropathy. This kind of fibroblast activation can also happen in your legs, along with an abnormal accumulation of GAGs like hyaluronic acid, like what happened in the eyes, and cause swelling, discoloration, and an orange peel texture, along with pain and tenderness of the shins. We call this pretibial myxedema. Graves' disease is the most common cause of hyperthyroidism. Therefore, in primary hyperthyroidism, it's important to exclude Graves' disease with a history and a physical. It's important to look for unique features of Graves, such as exophthalmos, and check if the patient has a diffusely enlarged thyroid gland. If those are present, you can make the diagnosis of Graves' disease and start treatment. But if you're not sure if it's Graves, you can check for TSH receptor antibodies. If they are positive, you can make the diagnosis of Graves' disease. If the antibodies are negative, you can do a radioactive iodine uptake scan. If there's a high diffuse uptake, that is indicative of Graves' disease. If it's more of a localized uptake, it could be a toxic adenoma or a multinodular goiter. If the uptake is low, it could be thyroiditis or exogenous intake, which you could differentiate with a thyroglobulin level. Now let's move to the treatment of Graves' disease. If the patient is symptomatic, you can use a beta blocker such as atenolol to control symptoms. There are 3 ways you can treat Graves' disease. You can reduce the production of hormone using drugs, radioactive iodine ablation, or surgery. Thionamides such as methimazole or PTU can be used to treat Graves'. However, it's important to ask the patient if she's planning on getting pregnant if you're starting methimazole, because methimazole is teratogenic and can lead to a life-threatening complication called aplasia cutis in the baby. Contraception can be recommended to patients taking methimazole. PTU, on the other hand, is safe to use during the first trimester. Radioactive iodine ablation is contraindicated in pregnancy, so it's important to check if a patient is pregnant or is planning on getting pregnant before recommending this treatment option. It's important to recommend dual contraception to these patients. Radioactive iodine ablation can also worsen orbitopathy, so if a patient is having orbital signs and symptoms suggestive of orbitopathy, we would generally advise against ablation. It's also important to remember that patients without orbitopathy prior to ablation may have a risk of developing new-onset orbitopathy. So this should be informed as well to your patients. Thyroid surgery is another definitive treatment option for Graves' disease. This is a good treatment option for someone who has Graves' orbitopathy. However, it's important to let your patient know that, like any other surgery, even this can be associated with post-surgical complications. Complications such as recurrent laryngeal nerve damage can lead to hoarseness. Since our parathyroid glands are located near our thyroid gland, they are at risk of being injured or removed or deprived of their blood supply. This can lead to a condition called hypoparathyroidism. Parathyroid hormone regulates our blood calcium level, so injury to these glands can lead to symptoms of hypocalcemia such as muscle spasms, tingling or numbness, fatigue, and in severe cases, seizures, arrhythmias, or even tetani. It's very important to make sure that your patients are informed about these complications. Removal of the thyroid requires lifelong treatment with levothyroxine, which is a synthetic form of thyroid hormone. Since you don't have your thyroid gland anymore, you're going to have to supply thyroid hormones to these patients exogenously, as these hormones play a vital role in metabolism. So it's very important to inform all these things to your patient before choosing a treatment option. And that brings us to the end of this video. Thanks for tuning in. Have a great day.